This podcast is for educational purposes only. The information presented is general in nature and is not medical advice, diagnosis, or treatment. Watching this video does not create a doctor-patient relationship with the hosts. Always consult a qualified healthcare professional regarding your individual condition before beginning any treatment or exercise program. If you are experiencing a medical emergency, seek immediate medical care. All right, everybody, welcome to the Two Bros and Some Joints podcast, where we are going to be talking about different kinds of aches and pains that patients have, what options for them may exist, some breakdowns on some common myths, and just chat about our own personal experiences with Dr. Nick and I in our own private practice. Dr. Nick is a rehab chiropractor from Jacksonville, Florida. He's been in private practice now for over 4 years at RTA Rehab Chiropractic, and I'm Dr. Austin from a rehab chiropractor from Omaha, Nebraska, in private practice now for 4 years as well, over at Body Kinetics Rehab Sport and Spine. We actually graduated together, and so we know each other just a little well. We were over in Daytona Beach, Florida. Our mission mainly with this podcast and this YouTube page is just to help elevate the chiropractic field through an evidence-based, patient-first approach to musculoskeletal injuries. Throughout these episodes, our job's simple: help you guys better understand your body and then the options that you have regarding some of like your aches and pains. And without further ado, Nick, the thing that we're talking about today is corticosteroid injections. It's something that we hear so frequently in our offices all the time. Mainly what we do in our offices is more rehab, more physiotherapy based, with chiropractic involved in some of it in a lot of these cases. But mainly today we are focused on cortisone. And the most common places that we hear about it is it appropriate for me to get it in my knee? Should I get a knee injection? Is it going to be helpful? What are the risks? What are the benefits? So without further ado, Nick, let's start talking about it. We hear kind of commonly two different kinds of pools of patients, right? Thinking about it today, like what we wanted to talk about, I could think of two different kinds of patients. The first is the first one who's already signed up for a total knee replacement, right? They're signed up for a TKA and they're going to have it. And they know that they're going to have it. And one of the people that I mentioned later is Dr. Udi Kerbel, very well-renowned knee orthopedic surgeon up in the Northeast. He's even talked about this as well. If you're signed up for a total knee replacement already, Nick, is it appropriate? Do I go have injections? Do I have more? Udi seems to think so, and I agree with Udi because of what the cortisone does to the joint, to the tendons, to the ligaments over time. Let's open up the conversation there. There's two pools of patients. The first one is the people who are already signed up for it.
All right. So, you're exactly right. When we're talking about these pools of patients and what they're actually dealing with, it changes what's actually appropriate. You take somebody who's, I love runner, and you say, hey, you got some knee pain. You should get an injection. Okay, well, let's talk about what these injections are actually doing and then whether it's appropriate. So for the people who are already signed up for a total knee replacement, the downsides are essentially not there. So what we have is the presence of these corticosteroid injections actually increases the rate at which the breakdown of the tissue and degeneration actually occurs. So people who get these injections every 3 months, 4 times a year or more, depending on what you're doing and what you're getting it and where you're getting it anyway, it actually speeds up the degenerative process. So for those of you who are scheduled in 2 months to have a total knee replacement, that degeneration doesn't matter because they're literally taking the joint out and replacing it anyway. So we're not worried about long-term downside effects of those corticosteroid injections. So in that realm, we're actually not worried about how much degeneration there because they've already decided we're getting this replaced. We've gone past the point of no return, and this is the only option left on the table for us. So in that, I would agree with you both in saying that, yes, this type of patient is where it's most applicable and best suited to actually get these injections.
Yeah. And that's what Dr. Udi Kerbel even talked about too, just to expand on that was, and I'll put all of his information down in the show notes as well, was it is appropriate for those people. You're going to go in there, they're going to go in there, and they're going to cut that stuff out anyways. So what does it matter? The one thing that I love about Udi, though, is that he looks at not just some imaging. He doesn't look at just some presentation, but the patient's actual lifestyles. So if your lifestyle is conductive enough that you already signed up for these things, perfect. They're going to cut it out anyways. you and I may end up being part of the rehab process, whether pre-rehab or post-rehab process. And so that's where I always refer to, like, we as a team, when we're signing some of our patients up for these things and helping them navigate it, it's completely appropriate. If, say, the surgeon's schedule doesn't allow for it for another 6 to 8 months, be our guest, go for it. It's going to be appropriate. You're in so much pain right now that you're having to have this surgery, that's our last option. The cool part is these arthroplasties and everything, like the surgical procedures they have, are so well developed. These things last well beyond like regular survivorship. Like I think the last time that they looked at like even like hip survivorship or knee survivorship, it was somewhere in like the upper like 90 to 98 percentile, where basically these people, the only way that they're ever having revisions is if something went like catastrophically wrong. So although yes, they do tell their patients, hey, there is a lifetime warranty on these things, the likelihood you ever actually end up having to have them replaced if you're actually in the appropriate patient population, appropriate pool, is so low, it's insane. So that's where
And
like
we'll
UD really go ahead.
I was gonna say we'll have one caveat onto that too.
Yeah.
A lot of the conversation comes around either a 10 to 20-year revision mark of like, hey, this is only gonna last so long when we do this replacement, whether it's a hip or a knee. And that also comes with how young you were convinced to get this surgery and whether the
Yeah.
surgery was actually the best option. So you might have been told, like, hey, this is actually like what I'm supposed to do. The doctor said I need to have a replacement of this knee, but you might be 40 years old and
Mhm.
you're still active in CrossFit or, running or lifting, whatever it might be. And you are getting this stuff way too young to the point that there is no chance that this is going to last you the rest of your life because you might have another 50 years left in you or more,
Yeah.
and then you're already getting this. That's when the revision stuff starts to increase the likelihood of you actually having to go back and get a revision.
Yeah, and that's why, and we hear it all the time. Is like some of our patients will tell us, "My doctor said that I'm too young." What do they mean by that? I'm in my 40s. I'm in my 50s. What do they mean by that? That's what they mean. Is just they're trying to tell you, "Hey, you're really healthy. You're really active. You want to live this really healthy, active lifestyle. We want you." Like as a whole team that is treating that knee, between us, between the PTs, between the rehab chiro side, between the surgeon and all of their staff, we want you to outlive it. We want that material to outlive you. You don't want to go have a revision. I know that Dr. Yudi Kerbel's even mentioned it multiple times, and even some of the guys at the Orthopedic Joint podcast and stuff have like talked about it that I listen to, where they don't want to have to do a revision. No mechanic wants to go back and redo work. That's not what they want to do. They want to do it once, crush it, and then you go out there and you have an amazing time because those are amazing surgeons and they're great at what they fucking do. Like nobody wants to
Exactly.
go take the eraser to it. They don't want to do that. It's not fun for them and it's not fun for the patient either. The recovery sucks. It's horrible recovery. I've had a few patients that have had to do revisions for shoulder, for rotator cuff tears, just for they actually tore the anchors out in one of the cases, and
Mm.
having to see a patient go through that is horrible. So I know we're talking about the knee, but again, they don't want to do that. No surgeon wants to do that. That's why I have such
Yeah.
a high degree of respect for the people that we look up to and we work with. These are amazing surgeons, and so that's why it's important too to like talk about like, hey, if you're already signed up for this, all of the evidence points towards go ahead, go for it. If you want to be more comfortable over the next few months, the evidence says so. The surgeons that we've worked with and that we talk to say yes to. Thumbs up, go for it. Right? There's nothing wrong with it. Would you agree then, too, Nick?
No, I would absolutely agree. Again, it also states, when you're looking at this, your timeline, surgery's not being, if it's not being, pushed out for some long term for any reason, scheduling wise, anything like that, or if it's not for 2 years, you might want to rethink what you're about to do with it, and rethink the physiotherapy, chiropractic, rehab realm first, because it's like, hey, you're going to wait 2 years. It's like you're going to get multiple of these injections. There are other systemic effects of corticosteroid injection as well that happen to it on a metabolic side of it as well. And it's not saying that you're guaranteed to get any of these things by any means, but it is something that I feel is overlooked in a lot of these pre-surgical consults, um, or any other treatment consult. They're not getting a full picture of what the ramifications of these treatments actually are on a full scope. And if you end up getting multiple and multiple and multiple over there, there is a systemic effect as well.
Yeah. So that actually brings us then, you're kind of talking about like the whole rest of the body. It brings us to a really good point where, yep, hey, if you're in that patient pool, there is nothing bad that we could say about it. Even the people who we're supposed to be on the other side, right? We're supposed to be the guys trying to convince you, like, no, don't do that. We're even telling you, yes, it's completely indicated. It's completely safe. Go for it. Like the indications, it works. We always joke in our office, and I know that you joke about this, is like medicine works. I promise. I am not anti any of it. It works. It's just chemistry.
It's all about using
It's
it when it's appropriate, and
yeah,
that's the thing that people just don't understand because they want to use it for everything.
yeah,
And that's where it kind of goes off the rails
yeah,
because everything has a time and place. And
yeah,
if this is not the time and place to sit there and look and get surgery, it's like we need to
yeah,
be thinking about something else, a different way and a different approach that's going to get you there, rather than just saying, well, I got a bum knee, let's go get surgery.
right,
That's the
right,
only way because so many people get convinced at way too early that that is the only way to do it. And
right.
again, we're supposed to be the people saying, no, you should never do that. Never let them cut open on you. Never let them do
Right.
this. It's like, oh,
And we're saying yes, go for it, right? It was like, hey,
it's
like
like,
if it's the right place at the right time for the right reasons, go for it. Yeah.
mhm,
I had one
absolutely.
patient who had a TKA, and his life is immensely better because of it. He's in his mid 50s and he is living his best life. He's a yoga instructor. The dude's a rock star, and he is doing a bajillion times better because of it. And was one of the things that we said, and we agreed, like, look, hey, this is just going to be temporary right now. You are going to do better because of this. And sure enough, he is. He loves it. He loves the way he's moving now. Like all shout outs to the surgical team that worked on that and the ability for us to help with like the rehab process and everything. It was magical for this person. So if you're part of that pool, yes, do it. It's all signs point to Lauderdale there. There's no argument. Now, let's talk about the other pool of people, the pool that we really care about, the pool that we see where there's a lot of nuance, right? And this is the pool. We'll kind of it's going to be kind of like a broad spectrum, which is if you're just a patient with just general knee osteoarthritis, maybe like a degenerative type meniscus tear, some patellofemoral pain syndrome, whatever we like to call that or name that nowadays, or just like some generalized patellotendinitis. These people we see frequently, these are probably more of the frequent flyers. That's why we talked about that first population first, is that is a much smaller patient subsection where those people are fully committed to having surgery. Those people are fully committed to doing the thing already. There's not much more to discuss there. But these people where, hey, my doctor said my joints degenerating, I have degenerative joint diseases, da da da. With these people, I'll preface this by saying when they come to us, Nick, they usually say one thing. It's that, oh, the injection didn't work, right? That's like normally the thing that they hear is, oh, it didn't
That
work.
is so common. It's like, I got the injection. How long is it supposed to be until this thing starts kicking in? It's like
Yeah.
immediately, like
Yeah.
very, very
Usually.
quickly. It's supposed to be doing hours,
Right.
hours. You
Even
should start to
24 to
feel,
72. Yeah. Yeah. It
yeah,
should be
yeah,
pretty quick.
literally within the first few days. And I'll talk to people who's like, oh, I got an injection 2 weeks ago, and it's really not doing anything for it. It's
Yeah.
like, how long is it supposed to take? It's like, yeah, it's
Uh,
not this long, not
yeah.
this long.
No.
That's and again, like we said, medicine works. This stuff is chemistry. It does work and does its thing. But we have to sit there and ask, what job is it actually doing?
Yeah.
What is this thing actually supposed to be doing? When you ask providers when they're delivering these things, before going to chiropractic school, I've shadowed NPs, PAs, doctors, orthopedists, all these kind of things before I, tried to go through the pathway I was going. I had shadowed a physician assistant in an orthopedic clinic, and
Mhm.
every other person that came in there with a knee issue got a steroid injection. Almost every single one of them.
I think I
And
remember you
they'd sit
telling me
there and
about
ask.
that.
They'd sit there and ask, "Is this going to fix the problem?"
Yeah.
And the good part about what they said was absolutely not. This is not going to fix the problem.
Yeah.
But what they did do is they framed it exactly how we said earlier. Where it's appropriate is when you're getting ready for that total knee replacement surgery. They sat there and told those patients, no, this is not going to fix it. This is going to knock off the inflammation. The only thing, then they would end it, and this is where I shook my head at every time, is they'd end that conversation saying the only thing that's going to fix this is a knee replacement.
Yeah.
And you can tell me your thoughts on that conversation, but it was one of those, I have to hold my
It's
tongue onto this piece because I was like, that is incredibly short-sighted and saying
I
like the only way to fix this. is this. Well, okay, again,
I would have stapled my
definitions.
mouth shut.
Def I
It
had
would
you
have been so
foot insert. But so
open
again,
mouth insert
definitions
foot.
matter here,
Yeah,
though.
yeah, yeah. So let's talk
Definitions
about
matter
that.
here. So let's talk about, well, yeah. So definitions matter here.
Yeah.
Let's talk about what it means to fix this.
Yeah.
And so, are you using the right tool? Because when you're recovering from any injuries and anything like this, or seeing any provider for any
Yeah.
reason,
Yeah.
you have a couple of things you need to think about. It's um, am am I using the right treatment for the right problem at the right time?
Yeah. Yeah, and let's
And so
talk
that
about
stuff
that from
becomes
the
very
beginning
important.
too. Is like what cortisone, what the glucocorticoids do at a baseline level, they work. They chew up the inflammation. We'll keep it super basic. That's what they do. It gets rid of the inflammation. The goal then is, and where they can actually use this like diagnostically is like if they know that it's a joint related problem, the pain will start to go away. The problem is though is how much of the inflammation is contributing to it, how much of other things like lifestyle modifications that you talked about earlier is actually is if the problem is, hey, this person has a problem with appropriate load management and they have poor biomechanics, they've changed their gait over time because it's an antalgic gait, because they've had knee pain for 4 years, just chewing up the inflammation, solving the inflammation is not going to fix anything.
Right. And that's
That
actually
is a
the
band-aid. Now, there's nothing wrong with that because if the pain starts to go away, we've now bought ourselves this window where we can operate with it. And that's where I think so long as you do
correct.
something with it afterwards,
Well, and
it's
this is where
not
it's so
wrong.
missed. This is where so many things are missed. They'll do this injection and say, "Hey, you're good. Go ahead, go do whatever." And like you said, it's knocking off the inflammation, and that is one of the signals for the pain driver.
Mhm.
However, what caused the inflammation? They'll sit there and tell you that on X-ray, well, you've got so much arthritis in that knee. This is going to calm down the inflammation because of that arthritis, but you can't do
Yeah.
anything about that arthritis. So let's talk about why the arthritis is there in the first place.
Yeah.
Faulty mechanics, improper joint loading mechanisms, load management, load capacity, range of motion capacity, all of these different things that are learned. Whether you
Tissue.
had an injury, in high school, you'll change how you walk. You have these different compensations
Yeah.
on how you load it,
Or
and that stuff
even
matters with this.
or even more importantly too, when they look at just an imaging, and we've seen this over the years, even from when I was first introduced to the sports medicine field as an athletic trainer to now, how much has changed when we were still like an undergraduate university. How much has changed
Hmm.
where we used to be able to correlate, we'd say, oh, there is some correlative findings between imaging and what's going on clinically, and nowadays most people, most evidence, and most studies, and most surgeons will even say this, and every PT, physio, chiro that I'll talk to will say, stop correlating every radiographic finding to a patient. Just because they have severe degenerative arthritis in their spine does not mean that they are in pain. We've proven that how many times on CT, on MRI, on
So many
X-ray,
times,
where just because something's completely blown out, there's no joint that's left. It's like, well, the patient has no pain. It's like, okay, so then
and
we can't just blanketly state that that's the cause for their pain. There's other factors, like you said. Is it, how about their tissue load tolerance, their tissue load capacity? What are they doing at the gym? Oh, this is a mom of 3 who just started working out for the first time since all 3 of her kids graduated from high school and they're in college, and she has some more time, so she's getting back to the gym, and now her knee pain's ramping up. It's like, well, she doesn't have knee pain because of arthritis, Nick, right? She has knee pain.
right.
Well, probably one of the many reasons she did too little for too long, followed by too much too fast. But you'll have
Mm.
some bad players say, oh, it's because of the arthritis. It's like, well, no, she's had the arthritis yesterday.
And then
She
they're
went
going
to
to
the
tell them
gym.
that they can't do this anymore. They're going to tell them
Yeah,
you shouldn't be going to the gym. You shouldn't be doing squats because your arthritis here. This is just going to make this worse,
right.
and this is the worst thing ever for this. It's like, well, if that were the case, then our approach using squats and deadlifts and lunges to fix problems for people and help them improve their capacity and help get rid of pain and do these things wouldn't work.
Yeah,
But we see time and time again that it does.
yeah,
And there's this conversation that I've heard several times where they will go in and say, "Hey, what's your pain level right now?" Well, I answer 2 or 3, and they're like, "That the doctor says that's not possible with how much degeneration that you have
yeah,
in this joint.
yeah,
That's not possible. You should be at least at a 7 or 8."
yeah,
It's like, well, that's because you're correlating. you're trying to say causation for this, and there's no chance that this person's pain scale. It's like this is what they're experiencing. If you look at my X-rays, I had my X-rays done in chiropractic school from previous back injuries and things like that. Was told never to deadlift again, not to squat again. And you look at my X-rays for my low back, it's riddled with arthritis. So they say, but I've got zero issues in it, and I have a 600-pound deadlift.
Right.
There are obviously outliers,
Yeah.
but you cannot sit there and say like, oh well, you've got arthritis, you should be in a lot of pain. It's like, promise you, I'm not.
And we have mountains of evidence to suggest this.
Yeah,
Way
not just
too many
anecdotal evidence
studies.
of my own
Yeah.
personal take.
Yeah.
Yeah,
We
it's
have
not
we have
just
too
my
many
personal
studies
take.
now at this point that have proven the correlative versus causative data. And that's why I've always joked, like, at the very bottom of like a radiology report, it'll always say one sentence. Is that famous last words from the radiologist was correlate with clinical findings. It's always at the very bottom. It's like my favorite to read, because the radiologist is just saying, hey, this is what I'm seeing. I'm just reading the book.
CYA statement. The best CYA statement in medicine ever is correlate
with clinical findings. Yeah, which is perfect. But that's the radiologist's job. And that's why I love radiologists, is they're just telling you the truth. This is what I see. And we have 2 or 3 radiology clinics here in Omaha, Nebraska that I love. They are absolutely amazing. We refer to them all the time. But that's why I try and explain. It's like, oh, they said that I have this. And I'm like, hold the phone. You don't need to have pain in that area. And they're just saying what they're seeing. They are required to. But we can talk about what that means. So for these patients who are maybe they've been told that they have bone on bone arthritis, or maybe they have like degeneration of a meniscus tear or some patellar tendonitis or some minor tearing. So for these people, not only does the evidence state and suggest, hey, that probably this injection is probably not necessarily appropriate for you, and even what our colleagues and what we see in our clinics, hey, it's probably not completely appropriate, or if you are going to do it, here's the window you should play in. What should these patients do? Because if they are a patient who says, you know what, I do want the injection. I had one like 4 years ago. It worked really well. From my side of things, we talked about it a little earlier, was if you do have the injection, I'm not going to burn you on a cross or something. I'm going to say, hey, look, if you have it, please do something with that window. We bought ourselves a golden opportunity where you used to not be able to lunge. You used to be able to not squat. We know that the doctor recommended, hey, if you can build some strength around these areas, if you can change some of your mechanics at the gym, you might be able to start to help this thing. Now that you've had the injection, what should you do? Should I just rest it? Should I just chill? Hey, it fixed the problem, therefore I'm going to stop. Like, what should I do instead?
Well, exactly like you said, you have given yourself the ultimate window of opportunity here. And here's the thing about opportunity, and when it knocks, you better open the door. And so this is the kind of stuff that doesn't get pushed enough, is like when you get that injection and it does work by knocking that inflammation down, hey, I feel better. I feel like I can go do this stuff. You still have these faulty learned mechanical problems and joint loading issues that are going on here that are not helping you get to that next level. So in the next 12 to 16 weeks, you are probably going to have to go back and get another injection, because it's going to start creeping its way back in, because you didn't actually fix any of the problems. Again, we talk about what does it mean to fix. You're knocking down the inflammation, so you feel fixed because it feels so much better. But when we look at a functional movement assessment, it's like, yeah, your load management here is not where it needs to be to do the things that you're trying to do at the level you're trying to do them at. And so then we continue the same type of movements that got us in that pain. We just knocked off that inflammation off the top, so we're not getting that signal to our brain to say, hey, we don't like this. And then you continue those patterns, and so we continue wearing and tearing and doing these things that got us there in the first place. So then the likelihood, not just pain coming back, but actually getting worse and getting further down the hill than we're trying to go up the hill, that's a very high likelihood in the conversation there.
Yeah, and that's where you see those patients who are the repeat. I call them repeat offenders. They'll go back. They'll have it for 4 months. They won't do anything about it, because it does feel like, whether they interpreted what the physician said, is, oh, the problem's solved now, or hey, this should fix your pain. And I'll be the first to say, in just about anybody in our field, there are bad players, there are bad apples in every field. I will never ever claim that any field is perfect. Our field itself is notorious for being that way. It's why we even joke about the fact is, like, trust me, I love the physicians I work with. I think the surgeons, the PAs, the NPs, the everybody that I work with, that I co-manage so many patients with, I love them. What they do works. You can't argue it. But the difference is did it work? Yes. The chemistry, everything behind that injection, it works. Your definition of working is, did I get the result that I wanted? Those are two different things. They are distinct and different. So if the cortisone works,
you got to the outcome
Yeah.
because you have that initial pain's gone.
Yeah.
Versus I wanted to run a marathon.
Yeah.
Pain's gone, so I did all this stuff, and then in 6 weeks you're crippled again. You can't get off the couch because the knee hurts too much.
Yeah.
So
those are two distinct
thinking
different
you
fields.
got the answer versus getting the answer to long term are two different things that are very distinct.
Yeah. So for those people, then what I guess the best move for them, and this is where, like, obviously we kind of we toot our own horns here, is we start to look at, like, if you are this person, basically, let's start there. If you are this person who maybe you did go back to the gym, you flared up your knee, you went to the doctor, they said that there's a little tear in the meniscus that's there, it's probably degenerative, blah, 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 but they told you have a torn meniscus, maybe you've got some osteoarthritis, there's some nasty arthritis that's in there. For us, from you and I, and this is where we could basically pretend that we can co-manage this patient, is like, if you are that patient, Nick, and whether they do decide to have the cortisone injection, again, we talked about, hey, take that new window. What should we be doing in that window? Because for me, the first thing is, at least, okay, let's say they do have the injection or they don't. We still have ourselves a window of time to work together. The first thing that I look at is okay, what does this patient's programming look like? Is it their first time back at the gym in 2 years? Did they start a new programming type? I want to look at, what are they doing? That's like what we define as like load management, right? It's like, what are you doing that potentially flared this up? Because it wasn't just magic, especially if it was like non-acute, where they're like, yeah, it kind of creeped up over a few months and then it started to really bother me and now it's really pissed off. That didn't happen because of arthritis. That didn't happen because of a meniscus tear. We know that those are typically acute instances, especially in a meniscus tear. It's an acute instance where we'll see something. It's like, oh, okay, cool. I planned it and twisted on the stairs because I was bringing my 32 pack of Busch Light up the stairs, and I twisted my knee because I was so excited because I forgot my other 32 pack downstairs. Like that's when that happens. So if this is not that person, they just went back to the gym, the first thing we look at is load management, right? Is, okay, how much are you doing? Right. Is it too much too fast? Did you do too little for too long? What else can we do for these people, and what should they be doing? If they're like, okay, all right, geniuses, you said load management, you gave me a bunch of fancy words, you two knuckleheads. Like, what can they start doing immediately?
So again, like you said, we're going to talk about what they're actually doing, what their lifestyle is doing. Do they sit all day for work and then they go and try and crush a CrossFit workout? Are they super active and they're moving around all day long? Are they new, fresh back into the gym after 20 years of not going? Or are they going after a new PR, which requires a lot of heavy loads and heavy volume in order to reach that goal? So what are the goals in mind that we're looking for here? So if this person is, relatively well trained and they're looking to put a 405 back squat, and it's like, okay, well, you're going to require a lot of load in order to get to this point, a lot of training, a lot of volume, a lot of work to get there.
I like that. Can I stop you there? Because that's perfect. It's like, I even think that even my statement right there, like, hey, I missed something too, which is like, for that patient, it's, hey, I don't want to have surgery, but I had the injection, or I'm against the injection. Where they need to start is like, what are your goals? What do you want to do? What do you actually want to do? Because like, yes, I understand. Yes, I understand you want to get out of pain. Like, let's like throw that out. Like, I get it. I don't like pain either. You know what I mean? I don't like it either. But what is it that it's keeping you from doing?
Exactly.
because
Yeah, we
there's
start
usually
with the end
something
in
tied to
mind.
the end. Yeah. Yeah, I
Yeah,
like
we
that.
start with the
Go
end in
on.
mind.
Sorry. I liked that
Um,
so much because that's what we do with our patients during our first consultation. I ask them, I'm like, what is it you want to do? It's like,
yeah,
put
and
pain
what do
aside
you
for
want to
two
do, and
seconds.
why
What
is
is it
this
you want to
important?
do? Yeah. Because you clearly want to do something and pain's getting in your way right now. What is it you want to do? And a
Yeah,
lot of them will
and so
sometimes
here's the
look at me
thing.
and they're like, that's a great question. I'm like, yes, it's the only question I care about right now.
Right, exactly. And so, yeah, when you think about that, it's like, okay, if your goals are to sit on the couch and not do anything, just not have your knee hurt, hey, you know what? Potentially, we can even ring you back in and say, hey, that injection might be worth your time because you don't
Yep.
actually need a high capacity to do stuff. However, if your capacity is dropped so low that walking that 24 pack of beer up the stairs is getting you, we still might need to rethink at that because okay, that's the goal. You need to be able to do stairs and single leg stability and strength.
Yeah.
We need to have to understand what's going on with this. So the next thing that we look at after figuring out where we want to go, figure out where they actually are now. So there's two frames that you can think about this in. Um, Understanding the actuality of where you are right now and saying, okay, this is what I can do pain free. This is where the pain starts, or everything hurts because I've pissed it off so much that every movement hurts it. Every type of plant twist, flexion, extension, any way you move the knee bothers it. Pressure bothers it. So then the next step there is figuring out the underlying issue of what's actually going on. Okay, so the image showed a meniscus tear. You might have a bucket handle tear. You might have mouse ears. You might have all these little things that are going on. But we'll talk about functionality and what you actually can do, and then pinpoint what the actual problem is. Because, like we said, we've kind of looped it into you're getting a knee replacement, as in is too far gone, or we have all these other groups. So it's basically I'm getting surgery or everything else. And
Mm.
so what we would actually do in my practice, we narrow it down and figure out, okay, you have what is now called patellofemoral pain syndrome, or patellar tendinopathies, any of these issues that are muscular in nature. That pain shows up around the tendon, around the kneecap, but we also have issues in the strength of the quad. We have trigger points showing this and saying, okay, I can actually reproduce your pain by this. That means that we have either a muscular involvement of this and why this is showing up, or we have a joint load problem because we're not managing the load through the joint. So then we have irritation of the meniscus because that meniscus is basically just a cushion between the two pieces of the knee where your tibia and your femur are coming together. And so what the actual problem is changes how we're going to work on this, what we're going to treat, and how we're going to get it there.
Yeah.
Some things may look similar, but the overarching theme of how we're going to do this changes. So
Yeah. And
identifying what the actual thing is that needs to be addressed after that inflammation's been knocked down by that
yeah.
injection, that would be the first place that I would start my practice.
Yeah, and I think you can even expand on that too. Is where we get a lot of patients that come to us and they say, "Oh, uh, my PT or my chiro or my surgeon said that my glutes are weak or my quad is weak or da da da." And I'm like, "Well, okay, you may have relative to what." That's one of the things that I like to write because we have this big whiteboard in our office, and I like to think if we can explain this at a level that our patients can start to understand things. Like when I say the words nociceptive inhibition, you and I understand as, oh, there's pain, therefore my joint, my tendon, my ligament, or my muscle is not going to contract nearly as hard as it is supposed to. Why? Because the brain knows there's pain associated with that movement. How do I explain that to a patient? Well, hey, it's not that your quad's quite like weak. It's that right now we're dealing with pain. And that goes back to the earlier statement with like, yes, go ahead. The injection's going to cut that pain out. That way you have this window. Guess what we can start to do? We can start to use your quad the way that it was supposed to be used in the first place. We
Mhm.
can actually get good force production out of that muscle so that you can actually get through a full range of motion of a lunge. That's how these things are supposed to be used appropriately. So now for those people who don't have an injection, who don't have that kind of like pain cut off, where they're like, no, it just doesn't seem appropriate, or I don't know, the surgeon smelled weird or something like that. Like whatever the reason may have been, if you decide not to have it, I like to think would it be crazy to say like, hey, I can't lunge, I can't get down onto a knee right now and get back up? Would it be crazy to say, hey, can we just work within 50% of the complete range of motion arc? Like, can we stop right before the painful arc starts? Oh, cool. Okay,
Exactly.
great. That doesn't sound crazy to the patient. That makes sense. I'm like, all right, well, what happens if we load it? Oh, it starts to feel better. Okay, cool. Some of the pain's starting to go away. Wait, I can actually get into this range of motion a little bit better. And then the next week we go about 5 degrees lower, 5 degrees lower, 5 degrees lower. Suddenly we spend 3 to 4 weeks doing this and you've made 20, 25 degrees range of motion of a difference. For a lot of patients, that painful arc, that's all the more that painful arc is. That's where I joke with a lot of them. It's not rocket science, guys. A lot of times this is just straight caveman unga boonga. If I strengthen an area, if I give it enough load and help build the tolerance around a movement, a lot of times the pain itself or that nociceptive inhibition that we were like perceiving as strength loss starts to dissipate. It's not magic. The brain itself is what I like to call like an overglorified breaker box. It really likes to just shut stuff off when it doesn't like what's being inputted. The problem with it is, and the cool part about it is that it's easily manipulated. You can teach it to do specific things. You can give it input so that it distracts itself. I mean, we learned that while we were in school, right? It was gate theory. It's literally just, hey, look over here, go do this thing now. It's literally how simple it is. It's so
That
simple.
point that you're making right there is huge. Like you said, we use concepts like gate theory, but anytime that you use icy hot, that's gate
Yeah,
theory.
yeah,
It is okay. My hand hurts. I put icy hot on here. Now I have that cooling menthol feel to it. I don't
yeah,
feel pain anymore because I feel the sensation of that
yeah,
overrides the pain signal. So when we're taking these things into light when we're working with these clients that have these issues, we have to know how to trick the brain into saying you're allowed to go here because
yeah,
what it is, like you said, it's a glorified breaker box, but your brain and your body is really good at stopping painful things by changing how you move, changing the range of motion, shifting your weight to the left side when the right side's bothering it to
yeah,
remove some of the load so it doesn't hurt as much. And it has this protective mode that says, hey, we're not going to go there because last time you reached up that high with your arm, or you bent down that low with your low back, or you squatted down and your knee bothered you. Last time you did that, we didn't like it, so you're not going to go there. So your brain stopped you from going there because it didn't like it. What we have to do is essentially override that signal and allow us to get that deeper range of motion, that strength build back up, and allow those muscles to fire appropriately so that we can build up those uh, tendon, muscle, joint capacities and allow the healing to start to go. Because, like you said, we'll start at 5 degrees, 5 degrees into that depth, 5 degrees in that depth. And by the end of it, it's like you got full range of motion and you don't hurt anymore. And
yeah.
when you think about it, 90% of your time is not dealt in those deep ranges of motion.
Right,
So you're not going to keep flaring this thing up unless you're
right.
dropping into the bottom of the squat with no stability, no
Yeah.
control, and you're just dropping and catching the weight at the bottom. Um, you're
Well,
going
and
to be able to control that better.
I think a lot of people get concerned that if they push towards pain or they push into pain a little bit, is that they're damaging the area again. They're damaging it more. They're
Yes.
doing more damage. Pain doesn't always mean damage. Can it mean damage sometimes? Yeah, sure. If your ankle's not pointing the right direction anymore, your knee's not pointing the right direction anymore, I probably wouldn't start loading it. It's probably not a great idea.
Probably not a
Like,
great
it's
idea. Yeah.
probably not a good start. Yes, you probably are causing more damage. Why? It's not pointed the right way. It's
It's just
not.
like this is
You're
inherently
already
this way. Yeah.
you're already up Shit's Creek. Don't throw the additional paddle in the back out too. Like, just leave it alone.
Exactly.
There's a time and place, and that goes back to our earlier conversation. Like, if you are one of these patients that is struggling with these things, there's an appropriate there's a right place at the right time for the right reasons within the right patient to do these things. There are plenty of reasons to have an injection. There are plenty of reasons not to have an injection. You have to start to ask yourself, am I the right person? Is this the right time? And do I have the right reasons to do this? Because if you are going to do that, are you signed up for surgery already? Yes or no? If you are, fantastic. I've got plenty of colleagues that I will happily refer you to, that if you're not already working with them, I am happy to do it. I have had multiple patients who have had them, and they are so happy. And we were part of the rehab process, and it was fantastic. But if you don't want to, and you feel like you're stuck in your last position, there are people like Dr. Nick and I that exist within your area that can help you. Any good physio, any good PT or rehab chiro can start to help with this. But it's finding the right person at the right time for the right reasons and meeting them where they're at. And to go back to what you had mentioned earlier was, it does that place, does that doctor, does that practice, do they start with the first and most foremost thing? Do they ask you, if you are the patient looking for something like this, did they ask you about your goals? Did they ask you outside of your pain, why do you, like, what is it you want to do? If they've asked you that, you're in the right place. That is the biggest green flag I can give advice for. Is if you're trying to find a place, please, please, please make sure that they are focused not just on your pain, not just on, oh, well, here's a functional outcome scoring, here's a COOS, like, here's this mapping that we're going to do, this is the process. Please make sure that they are focused on just your goals, because at the end of the day, that
And
is what matters the most.
one piece on that, it's like, it's not because they want to ask questions and want to make you fill out forms of, well, we care about where you're trying to go, we just want you this for this, and they're those people who are asking where you're trying to go and what your goals are. They're not worried about a quota, they're worried about you, and that's the thing that you really got to take into consideration, because so many people just feel like a number when they step in that office, and like, I'm surgery number 3 today. uh, so rather than
Pull your
saying
ticket.
like, oh, this, yeah, pull your ticket, wait in line.
Yeah,
Did you order the pepperoni? Yeah, here it is. Okay.
exactly.
But they're actually worried about like, where are you going? And because that means they have a stake in the outcome, not just like, well, I did the surgery, I'm done, I did my job.
Yep.
It's They actually are invested in what you get out of it, and whether you actually get the things that you intended to get out of it. Because if they start asking those questions, it means they care. And if they
Yeah.
don't ask those questions, doesn't mean that they don't care, but it means that they're either too busy or just they're not focusing on the right things.
Yeah.
And they're worried about doing that surgery, and they either think they have a god complex and they fix everything without ever having to go back and do a double look. But we see that stuff all the time. But if you can focus on that, it means they actually care and have a stake invested in the outcome rather than just whether they did their job, so to speak. And
Yeah.
that's a huge, huge win if you can find someone with that.
Yeah. So and that's what I think where we can kind of like tie it together is if you are a patient that's looking for help with something like this, with knee pain, and you're asking yourself whether those injections are right for you or not, obviously have that conversation with your surgeon, have that conversation with your physio, with your PT, with your rehab chiro. Ask them, is this the right time? Does this seem appropriate? And if each one of those professionals is in the right mind, has the right reasons, and they've asked you the right things about your right goals, then the majority of the time you're going to come to the correct conclusion. That conclusion is going to be different for every single person, and that's why Nick and I immediately won't say one direction is right or wrong. We even laughed at the very beginning that, like, hey, look, it works. It does exactly as intended. It's just a chemistry problem, guys. It's too much for my brain, but it does work, I promise. And so for those patients, just finding the right team to help with this, that's the only thing that matters at the end of the day. Whether you do end up having it or not, again, it's not wrong. It's not the wrong choice. It's just making sure that if you are doing it, you do it with the right intentions at the right time for the right reasons.
And one piece on that is, it's probably one of our favorite sayings, or responses to questions about this stuff. It is, should I do this or should I do that? And it's our favorite Huggies answer. It depends.
It depends. Yeah,
The
it
diaper
depends.
answer. It depends. It's We love to say it, but everyone hates to hear it because it
Yeah.
depends. It depends, and something
Huh?
that I hope that this conversation has brought to light is that it actually does depend, and depends what pool you're in, depends what your goals are, depends on what you're actually experiencing, depends on what's wrong, what the right treatment is for that. And as much as people hate to hear it, the reality is it just depends.
Yeah, I like that, and that's we'll end it on that. Is at the end of the day, it all depends. Let's have that conversation about what are the reasons? Is it the right reasons at the right time for the right person? It all depends. So if you are that person, if you are looking for help, we're gonna drop inside of the show notes at the very bottom links in the Jacksonville area or in the Omaha, Nebraska area. If you are looking for help with those things, our opinions are actually always, our consultations and our phone calls are always free, right? At least to get an idea as to whether or not we can help you, whether maybe you need to see one of our other teammates in terms of helping with joint health. If it's like, hey, we need to send you a surgeon, another PT, another rehab chiro, etc. our opinions in that side. If you are in those areas, you can always give us a call. You can always check out our websites. All of that'll be in the description below. And in the meantime, I think that's the easiest way to end it is should you have the injection or not? It depends. It depends. We'll see you guys. Yes, yeah. We'll see you guys next week. Where next topic we are probably gonna be talking about shoulders. It's probably Nick's favorite thing and my least favorite thing.
Personal favorite of mine.
It's my least favorite. My least favorite thing. I hate them. I hate them so much. But he likes them, so he'll have a lot more to say about it. So we will see you guys next time. Peace.